Hello, and welcome to our professional series. Today we have our guest, Dr. Tejal Patel. Tejal is a pharmacist and clinical associate professor at the University of Waterloo School of Pharmacy. Dr. Patel's research interests are in drug-related management of neurological conditions, in particular dementia, epilepsy, and Parkinson's disease. Her current research interests include the assessment, classification, and management of drug-related problems in persons presenting with cognitive impairment, as well as the frail elderly in primary care settings with a particular focus on medication management, capacity, and adherence to medications. Tejal is also on the board of directors of Epilepsy South Central Ontario and has contributed a great deal of her knowledge and expertise in helping particularly women with epilepsy. Her list of publications is lengthy and informative, and I am very pleased to welcome today Dr. Tejal Patel to speak about women and epilepsy.
Thank you, Cynthia, for that warm introduction. Hello, everybody. I am excited to be here, delighted to be here to give you, to chat about women and epilepsy. It's a issue that is near and dear to my heart, and I've been working on it for a few years now. So let's get started. I thought let's chat a little bit about why women and epilepsy. We know that there's about a little under 140,000 Canadians who have epilepsy based on data that's about 8 to 10 years old. In Canada, fewer women appear to have epilepsy, about 32 per 1,000. But generally, when we look at global terms, we know that it's almost equal. Both men and women have epilepsy or equal amounts of men and women have epilepsy, about equal amounts. But why are we worried about women with epilepsy? Well, there's a number of things that we need to consider specifically in women who have epilepsy. Things such as sexual and reproductive dysfunction, things that are near and dear to women's hearts, contraception, pregnancy, lactation. Those issues affect women specifically. Catamenial epilepsy is something else that affects women specifically. And then we also want to discuss a little bit about bone health, as well as some of the side effects that are cosmetic in nature, because they may be more, may adversely affect women's psychosocial health a little bit. So why is it that we talk about women in epilepsy? What's so special? Well, we know that steroid hormones can alter the excitability or the reaction of the brain nerves to seizures. So they increase when we have steroid hormones and they're out of whack or they're not in balance, they increase the risk of seizures, or they increase the excitability of the neurons. On the flip side, when patients have seizures, or when people have seizures, if they have epilepsy, or if they're on antiepileptic drugs, all three of those things can also affect hormones. What we also know is that estrogen is a proconvulsant. What does that mean? That means higher concentrations of estrogen can actually produce more seizures. Whereas progesterone is an anticonvulsant, so it actually decreases seizure frequency, or the number of seizures a person can experience. So an imbalance between estrogen and progesterone, especially as what happens with the menstrual cycle, can increase the risk of seizures specifically in women. And we actually have a term for that. About a third of the women who have epilepsy also have something called catamenial epilepsy. And when we look at the definition of catamenial epilepsy is periodicity of exacerbation of seizures in association with the menstrual cycle. What essentially that means is that the number of seizures, or the frequency of seizures, increases during certain periods of the menstrual cycle or of the period. And just now, when I told you that estrogen can increase the risk of seizures and progesterone can decrease the risk of seizures, the concentrations of both estrogen and progesterone vary during the menstrual cycle, during that period of a month. So whenever there is a higher concentration of estrogen in relationship to progesterone, then we get an increase in the frequency of seizures. So on this picture that I have on the slide, you can see that the red dotted line represents estrogen and the purple line represents progesterone. When the ratio of estrogen to progesterone increases, this period right here and this period right here can increase the frequency about a third of the women have in terms of seizures during those two periods. It's very important to then establish a pattern of seizures. It's important to recognize that sometimes the seizures go up at certain points during the cycle. It won't always be around the menses because there are two periods when this balance is a little bit off. So we encourage women to keep a diary of when they had seizures. And the reason we do that is because it helps us establish a pattern of seizures. And then we can give a short-term treatment in addition to other antiepileptic drug therapy that a woman may be on. We can then supplement with other treatments. Treatments that have been tried for catamenial epilepsy include drugs such as clobazam, acetazolamide, or progesterone. Now, the research in this area is up and coming. There's not a lot of research, and we're still discovering which drugs are effective and not effective. I wouldn't say all three of these are very effective, but these drugs we do use to treat catamenial epilepsy. The other thing that we may also recommend is oral contraceptives. And this is just so that we can regulate the cycle. So oral contraceptives may be recommended specifically in those women that have irregular cycles. And then these can be, help establish regularity of those cycles. Then we can establish a pattern of seizures, and it'll make it easier to treat those because you'll know when those seizures may. A woman with catamenial epilepsy will be able to predict when those seizures may happen, and then we can offer treatments during those time periods. So in addition to catamenial epilepsy, there's also some issues with sexuality, hyposexuality in particular with women with epilepsy. In comparison to just the general population, a higher percentage of women with epilepsy report sexual dysfunction, almost 1 out of 5 to 1 out of 3 women with epilepsy. And that may be due to infrequent sexual desire, so decreased sexual interest, a decreased rate of actual sexual intercourse, even amongst women who are married, women with epilepsy who are married. And some women also talk about some dysfunction with orgasms. Now, why does this happen? Some of it is related to epilepsy, but some of it is actually related to a particular class of drugs called enzyme-inducing AEDs. So in this picture at the bottom, this graphic at the bottom, see the first box says EIAEDs. Now, I'll use this term through the presentation, but what it stands for is enzyme-inducing antiepileptic drugs. Now, what these do is they increase a substance in our body called sex hormone binding globulin. When we increase this SHBG, what we actually do is decrease the amount of estrogen and testosterone that's in our body. And when we decrease the amount of free estrogen and testosterone, which is what we need free of these substances. We can't have bound substances. These free substances then decrease our sexual desire and may affect our the sexual dysfunction. So the reason I mention that is because fertility rates amongst women with epilepsy are also thought to be lower than the general population. Now, but that's based on the older data. The older data says that the fertility rates are about 60 to 80% of women who don't have epilepsy. However, there are newer studies, one study in particular, that showed that there was no difference in the number of women or the proportion of women who became pregnant, as well as the time it took them to get pregnant when you compare it to women who didn't have epilepsy. So similar proportions were able to do so. So that is up and coming. However, in the past, we did think that there were decreased fertility rates. I would say the answer is not completely, the question is not completely answered. And there are several things that can affect fertility that we do know occur in women with epilepsy. There's factors related to hyposexuality, which is what I just mentioned in the previous slide. And that could be things such as difficulty finding a partner, low self-esteem, or social isolation. We also know that women with epilepsy, about 1/3 of them, have irregularities in their menstruation. And when your period is not regular, that decreases the chance of getting pregnant. Also, women with epilepsy have certain disorders that occur with more frequency in women with epilepsy than in the general population. A good example of that is the polycystic ovary disease. And then, as I mentioned, antiepileptic drugs may actually have something to do with this issue as well, this issue of fertility. In particular, there was some good studies done with valproate that showed that valproate, which is also called Epival, produced menstrual irregularities, it produced weight gain, it caused some insulin resistance, it caused failure of ovulation, so failure for the egg to be released so that it can be germinated to cause pregnancy. And it was also, valproate was also associated with PCOS or polycystic ovary disease. So there are certain enzyme-inducing drugs that may produce these problems. And in particular, even valproate has been shown to cause some problems with fertility. Now, moving on, what about contraception? So this, again, is a very important thing to consider for women with epilepsy for a number of reasons. Two of the most important is the fact that almost all of the antiepileptic drugs have been associated with the risk of malformations in the children that are born to women with epilepsy. So that's the number one risk. The second risk that is that's of concern is the effectiveness of the hormonal contraception. So when I say hormonal contraception, I mean drugs such as oral contraceptives, the vaginal ring, the patch. How well those contraceptive measures work decreases with certain antiepileptic drugs. These in particular are the enzyme-inducing antiepileptic drugs. We have several studies that have shown us that the effectiveness of contraception, hormonal contraception, decreases when a woman is also using enzyme-inducing antiepileptic drugs. And we've also discovered that many women don't know of this interaction. So what they think is happening is they're being protected from conceiving a child. However, the oral contraceptive or the hormonal contraceptive is not working as well. And when that happens, they inevitably get pregnant. So it's an unplanned pregnancy. And then the fear of the risk of malformations goes up. So that, that concerns lots of women with epilepsy, and I've had several conversations about that. The mechanisms for this are very similar to what I explained with that graphic with enzyme-inducing and antiepileptic drugs. What they do is they increase how estrogen is eaten up by our bodies and thrown out. And so when that happens, our hormones levels go down and the drug becomes ineffective. On the flip side, lamotrigine can also decrease the levels of hormones in the body, ethinyl estradiol estrogen in the body, but it does so by a different mechanism. The other flip side of that is that our hormones can actually interact with lamotrigine and decrease how well lamotrigine works, and then that produces an increase in seizures. So the interaction between the oral contraceptives and lamotrigine is a two-way interaction. They both interact with each other. In terms of the enzyme-inducing drugs, they decrease the effectiveness of oral contraception or hormonal contraception. So then the important question is, which antiepileptic drugs interact with the hormonal contraceptions? And so what I've done here on the slide is presented two columns. The column on the left lists all the antiepileptic drugs that is likely to cause a failure of hormonal contraception. So it's likely to decrease the effectiveness or how well hormonal contraception works. And in this list are some very well-known drugs, some old drugs, carbamazepine, phenobarbital, phenytoin, primidone. Those are all some of the very old drugs. But also listed in this column are some of the newer drugs, such as Aptiom or eslicarbazepine, oxcarbazepine or trileptal, as well as rufinamide. With perampanel, we've discovered that the interaction happens when the dose of perampanel is more than 12 milligrams per day. However, we don't actually dose to that level. As long as you're below that level, the interaction should not be of concern. On the other column, the column on the right-hand side, these are the drugs that are less likely to cause a decrease in how well the hormonal contraception works. You'll see some of your old drugs like Zerontin, ethosuximide, gabapentin, valproate. You could call lamotrigine older as well. But some of the newer ones are also listed. So stiripentol, as well as brivaracetam. Now, brivaracetam at doses of 400 milligrams did show some decrease in estrogen, but since this is a very new drug, I think we need to continue doing more research to truly discover how much it interacts with oral contraceptions. So that's something to keep in mind and to take away when you're chatting with your doctor about which oral contraception to go on. It's worth discussing whether there's going to be a failure of your oral contraceptive with the drugs that you're on to treat epilepsy or seizures. So some of the other recommendations we have for women who are already on enzyme-inducing antiepileptic drugs is to use a higher estrogen content. Now, we used to have some oral contraceptives that had 50 micrograms of estrogen or estradiol, rather than the 20 to 35 that's available in the newer compounds. We used to have it for a while. It used to be called Overall 21 or Overall 28. That product is no longer on the market. However, I do know that some docs will maybe ask their patients to take 2 of the lower estrogen containing tablets a day. So it's worth a discussion. And in particular, what the question I would ask my doctor is, how much estrogen does this have? Am I on a drug that interacts? And if it's lower than 50, how do we address this? The other thing that I've heard doctors do is talk about or ask their patients to take continuous oral contraceptives without a pill-free interval. So as you know, in most cases, what we have is 21 days of a drug-containing pill or in oral contraceptive pills, and then 7 pill-free days or placebo pills with no drug. What we advise is that we use continuous combined oral contraception for 3 months with a 7-day break at the end of those 3 months. And this is called long cycle. It's also called tricycling. So that's another option to talk to your doctor about with. The other types of contraception, such as Norplant and progestin-only oral contraceptives, they have been shown to be not as effective as well. So this kind of affects almost all oral and hormonal contraceptives out there. There are a few other options besides those two. Of course, when it's possible to change your antiepileptic, that might be worth a discussion. I do not advise that we do it by ourselves, but it's worth a discussion with your doctor about what option works best for you. Medroxy progesterone or Depo-Provera injections, those appear to be effective. They're usually administered every 10 to 12 weeks. I've written condoms and vaginal diaphragms as well. Sometimes it's good to combine those two methods. The best method, though, to prevent conception or prevent a pregnancy is IUDs. Whether you use the Mirena or the copper IUD, they appear to be the best option in terms of providing a good, effective contraception, especially if you're on enzyme-inducing antiepileptic drugs. If those IUD options are not something that you're interested in, then yes, talk to your doctor about higher estrogen, continuous oral contraceptives for 3 months with a 7-day break, and also using a supplemental barrier method, so a condom or a diaphragm. And by itself, the condom or the diaphragm is not as effective as the hormonal contraception. But if you can't do one of the other things, such as high estrogen content or continuous use, then strongly consider using a barrier method. I would say use a barrier method if you're going to use any type of hormonal contraception outside of the IUD. So moving on, other concerns that are of particular importance and are related to pregnancy are things such as the rate of malformations that can happen with antiepileptic drug use during pregnancy, what happens to seizures during pregnancy, and then also what happens to drug concentrations during pregnancy. All three of these things are something that your doctor will be thinking about as you go through your pregnancy. So there are some risks with pregnancy in a woman who has epilepsy. There is a higher rate of complications during pregnancy. There's a higher rate of spontaneous abortions in women who are on treatment with antiepileptic drugs. There's a higher risk of pregnancy-induced high blood pressure, also known as preeclampsia. There's a higher rate of delivery complications, a higher rate of surgery during delivery, as opposed to cesarean. What I mean is cesarean sections as opposed to delivery through vaginal delivery. And there's a higher rate of status epilepticus as well. The one other thing that's quite concerning is that more women with epilepsy die during childbirth than the general population, and also during pregnancy. And so the seizure control is very, very important. And so, women may think, well, if this is going to be the risk of using antiepileptics, maybe I should stop using it. And then what happens is their seizure control worsens. And if seizure control worsens, then there are other risks that come with worsened seizure control. So it's very important to have a very clear discussion with your doctor about the risks and benefits. There is an increased rate of malformations when a fetus is exposed to antiepileptic drugs during pregnancy. But the best news, the good news is 96% of pregnancies in mothers with epilepsy produce normal children. And that should be something that should be something positive that we take away, that 96% of all pregnancies result with normal, healthy children, and we're not really facing an issue. However, having said that, always good to have a discussion. Some of the things that you should consider in terms of antiepileptic drugs that increase the risk is one, valproate. Of all the drugs, we definitely know that valproate carries the most risk. Then there are other things that are also worth discussing, whether you should continue one drug or whether you need to be on many anti-epileptic drugs during pregnancy, whether it's necessary to stay on the same dose or whether it's necessary to increase the dose or decrease the dose. And finally, any combination that has valproate, if you are on more than one anti-epileptic drug, and in that combination you have valproate, then the risk of malformations does increase. It's consistently, so valproate is also known as Epival, is consistently associated with poor outcomes. The MCM stands for major congenital malformations. It is a dose-related effect. So we see that it happens with valproate, but the rates of the malformations go up once we increase the dose, especially doses higher than 600 milligrams per day. So 600 to 1500, the risk does go up. Anytime you have a combination product or you're taking more than one anti-epileptic drug and in that combination is valproate, then the risk also increases. We've also discovered that in children who are born to women who are taking valproate during their pregnancy, we see delays in their developmental milestones. So these children have delays in their cognitive milestones, in their psychomotor milestones, as well as their language development. So ability to do things that require motor development, the ability to speak or not speak as much as the language that develops, that may also be delayed or lower in children exposed in utero, so during pregnancy to valproate. There's also the risk of neural tube defect, which is just that the spinal cord, the area in the back where the spinal cord is does not close and it remains exposed. And then recently we've discovered that valproate is also associated with higher rates of autism in children, as well as attention deficit hyperactivity disorder. The other drug that also poses a risk is phenobarbital. And some people may think that the risk with phenobarbital is also very high. You can see that the rate of congenital malformations is about 6 to 13% in valproate. In terms of the other antiepileptics, I mentioned previously that almost all of them also cause major congenital malformations, but the rates are much lower. You'll see that with Keppra, it's up to about 3%. With carbamazepine, it can be up to about 5%. Carbamazepine research has also shown that the risk increases with higher doses, so more than 400 milligrams per day. Same thing with lamotrigine, increased risk with doses of greater than 300 milligrams per day. So with all of these anti-epileptic drugs, it's very important to talk to the doctor about the risks and very, very important to start thinking about pregnancy well ahead in time. I usually tell the women I talk to start planning a pregnancy 1 to 2 years before, the pregnancy, so that we can start thinking about what drugs you're on, what the risk is, how to make sure that we can find the drug that works best for the seizure, and then change that drug with adequate time. And also we might need to try 1 or 2 drugs if the first one we try to move over is not working as well. It's especially important if you're on valproate to have those discussions. Now, some of these risks have variations in their percentages. So you'll see Keppra says 0.7 to 2.8. It's because the numbers come from different studies done across the world in different countries through different methods. So the rates will always be a little bit different. We only have very little data for some of the newer drugs, including eslicarbazepine, brivaracetam, lacosamide, perampanel. I expect over the next 4 to 5 years, we'll start seeing some more information filtering through about their risk as well. So what should you do? I mentioned that talking to your doctor is very, very important. So before pregnancy, we want to make sure that, there's a reason, a clear reason to be on an antiepileptic drug. That if you've not had seizures for a long while, to have a discussion about, is it worth coming off the drug if that's possible, and it may not be possible, but if it is possible, how do we do it? And we also need to understand, well, if I'm coming off the drug and then I have seizures, what happens then? The next thing we might want to think about is to trial drug therapy with just one drug. So if you remember, I mentioned that if you have more than one drug, then the risk of malformations increases. So we want to try to see if we can control seizures with one drug at the lowest dose possible. Switching antiepileptics, especially if you're on valproate, avoiding doses greater than 700 milligrams if you need to stay on valproate, to try to manage seizures in doses less than 700. And then getting some levels at the beginning of pregnancy, so we know that if during pregnancy those concentrations or the levels in the body start changing, then we can start adjusting drug. What we've discovered is that if a person stays seizure-free for 9 months, if a woman stays seizure-free for 9 months before pregnancy, then there is a higher chance she'll remain seizure-free during pregnancy. So it's very important to try to get that to that point for 9 months. Folate supplementation is very, very important. And the doses recommended are from 0.4 to 4 milligrams. Some doctors will even use up to 5 milligrams, especially in people who are taking higher risk drugs such as valproate, or if they have a family history of spina bifida or neural tube defects. We have seen that folate supplementation may actually also impact autism. So women who are taking folate have have a lower risk of having children who have autism. Other things to do is to stop smoking, and that may take a few tries and effort to do, as well as we see more increased weight gain and eating disorders, and sometimes it's necessary to bring that under control as well. So before pregnancy, a good discussion, some really good planning is very, very important. During pregnancy, seizures may increase in about a quarter of the women. In a quarter of the women, they actually decrease, and about half the women, they stay about the same. There are some studies that have shown that up to 3/4 of the women may experience seizure freedom or no seizures during pregnancy. And as I mentioned earlier, if you're seizure free for 9 months pre-pregnancy, higher chances of remaining seizure free during pregnancy. Once a person is pregnant, we try not to remove the antiepileptic drug, because withdrawing it fast or withdrawing it may produce seizures, and then that produces its own risks. So once a pregnancy is established, we try not to muck around with the antiepileptic drugs too much. So that's why it's very important to plan well ahead of time. There are certain drugs whose concentrations do fall during pregnancy. For example, lamotrigine, Keppra, Topamax, or oxcarbazepine, or triliptal. The concentrations of those drugs do fall during pregnancy, and it's related to lots of different factors. So doing levels during pregnancy is very important, and adjusting the drugs based on those levels, the doses of the drugs based on those levels is also important, because we don't want the levels to fall too far, because then we'll have an increased risk of seizures. Important to note that phenytoin concentrations are reported as total and free. Remind your doctors to think about the free and not the total, because free is the active drug. And then also remember that nausea and vomiting may affect drug absorption. So to keep that in mind as well when we're looking at concentrations. If we have a terrible vomiting during pregnancy, then we won't absorb as much drug. And we need to establish that before we continuously increase the dose. We need to continue folic acid during pregnancy. Most women with epilepsy are considered high risk, and so you'll likely be seeing a specialist for the care of your pregnancy. After pregnancy, very important to remember that, especially if we increased the doses during pregnancy, after pregnancy, we may need to decrease the doses of antiepileptics because once pregnancy is resolved, those concentrations will be too high. So remember I said they were dropping. After pregnancy, they may go up. So something to think about and remember to discuss if it hasn't been mentioned to you. We do see higher rates of postpartum depression and anxiety among women with epilepsy. So that needs to be addressed. That needs to be remembered. Bring it up if it hasn't been discussed with you. Also remember that once the baby's born, then we need to rethink about the contraception as well. Make sure that women with epilepsy go back on a contraception, especially if they don't want another pregnancy. Sleep deprivation does happen when we have a new baby, and so remember to think about that. If you start increasing, if you start having more seizures, remember to think about both the concentrations plus of the drugs in your body plus the sleep deprivation that may happen. And again, then start planning for your future pregnancies. Another thing that I would encourage all women with epilepsy to reach out for is support for employment issues, especially reach out to social workers if you have access to them, for social issues, for ensuring that you stay connected with the community while you're at home with your baby. The other question that comes up often is breastfeeding. Now that I've delivered and I'm taking antiepileptics, what happens to my baby? Will my baby get some of those drugs in breast milk? So first and foremost, remember that breastfeeding has a lot of positive, well-established effects. It provides nutritional value to your children. There are enzymes in the milk that promote digestion and absorption in the baby. The breast milk has substances that allow protection against infections. Babies who are fed breast milk have less eczema, they have less food allergies, it's inexpensive, it's simple, you can carry it with you. And then it also allows the mother and child to bond. So know that there's a lot of positive effects of breastfeeding. Many of the antiepileptics are expressed in breast milk, and we're still learning more about them. There's more research going on to see how much of the concentration or how much of the drug actually makes it into the breast milk. And a study that was just published this year says that the concentrations are minimal for most drugs. For lamotrigine, there seemed to be more variation, but for many of the older established drugs, very minimal, very small concentrations make it into breast milk. So there is a need to balance the risk and the benefit of breast feeding. There are a few institutions that have released some guidelines on what drugs are considered safe during lactation or during breastfeed. And you will see that most drugs are considered safe or moderately safe. And I've highlighted these with the green and the orange labels, and you'll see most of the drugs listed there. There are two drugs that are considered unsafe, and that's clonazepam and ethosuximide. And for those, what I would do is have a good discussion with your doctor, because it's necessary to understand the effectiveness for seizure control versus how much of it is in the breast milk and getting into the baby. The one thing that most doctors may advise you is to monitor your baby for, whether they're thriving, whether they're sucking well, if there's poor suck, if they're overly tired, overly drowsy, if they're not gaining weight as much as they should be, or if they look really excitable. Those are things that, may be the result of some drug leaking into breast milk and then into the baby. Those would be things I would monitor for and then discuss with the doctor. Other things that we could do as clinicians is we can test for liver function, we can test for some parameters in the blood, as well as concentrations of the antiepileptics in the baby themselves, if we think there is an issue that we need to address. And finally, the last thing I wanted to talk about was menopause. So menopause, early perimenopause and menopause among women with epilepsy, it does occur earlier than women generally. And so the thing that may happen is that potentially we have a shorter window for fertility in women with epilepsy, just something to keep in mind. Seizure frequency can go up during perimenopause and then decrease during menopause because of the changes in the hormones during that perimenopause time. Perimenopause time just means around the time when you're going through the changes for menopause, before menopause is established. Remember that hormone replacement therapy may increase seizure frequency because it does have estrogen in it. And also, just as I mentioned earlier, if you're on lamotrigine, going on hormone replacement therapy may decrease lamotrigine levels and then increase the number of seizures you're experiencing. So again, things to talk about. Some people may forget to discontinue contraception. If they're on contraception, just to remember that that's something that needs to be considered as well. And the final thing I want to touch on is bone health. The association between antiepileptics and bone disease was initially reported in the 60s. And over this past since the 60s, what we've established that there are some vulnerable populations, people who are in institutions and don't get enough, sunlight, vitamin D, women who are postmenopausal have a higher risk, older men, older children, and those who are on enzyme-inducing drugs. So postmenopausal women who are on enzyme-inducing drugs will have a much higher risk of osteopenia, osteoporosis, decreased bone mineral density in your ribs or spine or neck or hips. And all of this results in an increased risk of hip fractures. So again, if you've been on antiepileptic drugs, in particular enzyme-inducing antiepileptic drugs, and you're getting to that, you've been on it long-term, you're getting to that perimenopause, menopause stage, it's important to have that discussion about what do I do to prevent bone disease. Phenytoin, phenobarbital, primidone, those are the three drugs listed at the definite connection between bone loss and fracture. With carbamazepine and valproate, there's been some conflicting reports. The new antiepileptic drugs, we don't know very much yet. We're still researching them. What we do know is the number of years one stays on antiepileptic treatment, the number of drugs one uses, and whether it's enzyme-inducing or not. Those are the things that impact the severity of the bone disease. So what do we do if you're on an enzyme-inducing antiepileptic? It's the only one that's effective. You have taken it for a long time. What I would recommend is make sure you have adequate calcium, about 1,500 milligrams per day. Make sure you're on adequate vitamin D supplementation. So at least 800 if you're taking calcium, higher if you're using it alone. So that should actually say 1,800 to 4,000, not 400 international units per day. Some physicians may opt to treat with bisphosphonates. It's a drug class that's used to treat osteoporosis. So it depends on the physician and whether they've done BMD scans or not, but they may opt to treat with drugs such as bisphosphonates and calcitonin. Something to discuss with the doctor. One other thing, there's some cosmetic effects of antiepileptic drugs. I find that women are a little bit more bothered than men by some of these. For example, phenytoin can cause what we call coarsening of facial features. So it kind of, causes facial hair growth, causes gingival hyperplasia, so overgrowth of your gums. There are certain drugs that cause weight gain, so valproate, gabapentin, pregabalin, Viatrin, they all cause weight gain, whereas topiramate causes weight loss. And valproate also causes some hair loss. So again, if you're having some of these side effects and you're not sure how or why this is happening, it may be related to a drug. And again, worth a discussion with your doctor. Now, the last thing I wanted to highlight was the work that we've done with Epilepsy South Central Ontario. That's the University of Waterloo, and an initiative called Pharmacy 5 in 5. We were able to get some funding from Women's Exchange, which is located at Women's College Hospital, and they gave us a little bit of funding to develop an infographic and a video. And the infographic that we developed is a 2-page infographic. The first is called Pregnancy and Anti-Seizure Drugs. And everything that I just spent the last 45 minutes talking about is on these 2 slides, on these 2 infographics. The way to get to these, I won't go through all of these because we've already talked about all of these. If you want to print out a copy for yourself, feel free to email me and I can send you one. But if you want to print it out for yourself, what you can do is Google search for pregnancy, anti-seizure drugs, Waterloo Pharmacy, and it should lead you to this page where you can download and keep it for yourself. I've provided the link at the bottom as well. And when you click on the link, it gets you to that page. The second page actually talks about contraception and anti-seizure drugs. And again, we've tried to present it so that it's very clear, it's to the point. And again, this is also available at the Waterloo Pharmacy website. If you just search for contraception, anti-seizure drugs, Waterloo Pharmacy, you'll be able to get to this page. If you have difficulty, of course, reach out. The last thing we've done is created a video, and I will play the video because everything that's listed in those infographics is in this video. So I'm going to go ahead and play it, and fingers crossed it will work.
Here are 5 things women with epilepsy should know about how anti-seizure drugs affect birth control and pregnancy. First, many anti-seizure drugs can make hormonal birth control less effective. This can increase the risk of an unplanned pregnancy. If a woman is taking one of these drugs, better birth control options include an IUD, medroxyprogesterone depot injection, or a birth control pill with at least 30 micrograms of estrogen that is taken every day of the month with a break about every 3 months. Second, the estrogen in birth control pills and patches can make the anti-seizure drugs lamotrigine and valproate less effective, leading to more seizures. Women may need a higher dose of lamotrigine or valproate to control seizures. Third, all anti-seizure drugs increase the risk of birth defects if taken during pregnancy. The risk is highest with the drug valproate. The risk is also greater when anti-seizure drugs are taken at higher doses and when multiple anti-seizure drugs are used. Fourth, all women with epilepsy who want to become pregnant should plan well ahead. Anti-seizure drugs may need to be changed. Women who are seizure-free for at least 9 months before pregnancy are less likely to have seizures during pregnancy. All women taking anti-seizure drugs should take 5 milligrams of folic acid daily. Finally, it is generally safe to breastfeed while taking most anti-seizure drugs, but watch the baby for poor suck, poor weight gain, drowsiness, and being unusually excitable. It may be necessary to adjust the timing of breastfeeding.
I'm not sure if you're able to see that or not, but hopefully you did get to see that video. And then I will end this talk and take questions.
Tejal, thank you very much for this in-depth and thorough, informative presentation. Even though it's a complex presentation, and you presented in terms that are most of us can understand, and it was most interesting. Initially, I'd like to get to a question. We have several questions, but this one I think is a bit urgent. And so somebody was feeling teary, and this was making them cry. And the question, they said, I'm not understanding how persons with epilepsy have a 96% healthy baby, yet all of those medications cause birth defects. Am I missing something?
So what I was trying to say is that in 96% of pregnancies with women who have epilepsy, they have healthy babies with no concerns. In the 4%, there may be a cause for concern. If you're on antiepileptic drugs, most of the babies that are born are healthy, but these drugs do increase the risk of those malformations. So it's always a good idea to talk to the doctors about the risk of malformations. Most of the babies will be fine. A small percentage we may need to talk to the doctors about. And the risk depends on the drugs that you're on. What we do know is that valproate increases the risk a lot. The others do not. The higher the dose, the risk increases. If you've had a family history of something, of a malformation, then the risk increases. So the risk for most women is very, very little, but in some women, we may need to discuss that.
Yeah, thank you. And the Epival is?
Epival is
right?
valproate, yes.
And someone's asking, is it valproate in phenobarbital?
No, valproic. So valproate is known by several different names. It's called sodium valproate or valproic acid or Epival. That's a different drug than phenobarbital. Phenobarbital is a separate drug. It's an older drug, and the use of phenobarbital has decreased tremendously over the past few years. And what we are seeing in terms of trends, even valproate is going down, but it remains a really good drug for seizure control. Valproate does, but it is concerning in women for those reasons I mentioned.
Thank you. The questions, we've got some very concerned women on the question panel here. So what would happen if someone had suffered SUDEP while pregnant? Are there any studies on that? And what would happen to the unborn child?
So there's very few.
Maybe the second question is, what would happen? It's okay.
So there's a very few studies of SUDEP in pregnant women. We do know that status epilepticus increases. So those periods of time when you have long-lasting seizures, those are emergencies, those go up. But we have very little data on SUDEP during pregnancy. In terms of outcomes for the baby, I don't know enough. And I don't think there's enough out there published to give you a firm answer on what happens to the baby. It likely depends on how soon the person is discovered after having that event.
Okay. And is there harm to an unborn child if someone has a seizure, other than if there was physical?
So it does depend on the type
of harm to the baby from the actual seizure.
Okay, so the question is, will there be harm from the baby from the actual seizure? It depends on the type of seizure. So if you have a partial seizure or a complex partial seizure or focal seizure, that's not going to be harmful to the baby. If you have one of those generalized tonic-clonic seizures and you fall to the ground or something happens or it lasts a long time, that may produce some harm, but it depends on so many different factors that it's not as clear-cut. We know that focal seizures likely will not harm the baby. The generalized tonic-clonic seizures may, depending on the circumstances around that seizure.
Thank you. There's a question about genetics. Women who pass epilepsy on to their children, even with a planned pregnancy, this woman is expressing the fear of passing epilepsy onto a child is preventing her from having a baby.
This is something that you definitely want to talk to your doctor about. It may be advisable to get some genetic counseling for this. You know, there are different risk profiles for different types of seizures and different epilepsies. And if you're truly worried about what the risk is going to be of passing it on, so to speak, that's when it's very, very important to talk to your doctor, but also talk to a genetic counselor, and they can lay out what the risks are for you so that you can make an informed decision. I wouldn't be as worried about what the risks are until I spoke with someone who would be able to lay out the risks. Different women may have different types of epilepsy, different types of seizures, and there's different genetic profiles associated with that. So I would encourage you to talk to your doctor and then also talk to a genetics counselor about that.
And your presentation really does drive home the fact that be prepared. Knowledge is key. Plan ahead if possible. You know, I just wrote my own notes. Take folic acid well ahead of becoming pregnant. Mentally prepare yourself for a possible postpartum depression and maybe research that. You can reach out to Epilepsy South Central Ontario for counseling on that.
Mm-hmm.
You can plan your drugs around morning sickness, and so that you were explaining the vomiting can deplete the drug in your system, and just know all the information on your AEDs regarding your breast milk after, and the more you research during, as you said, there's a 4% chance of something happening, but that can be minimized as well by planning and preparing and getting as much knowledge as possible. Yeah. And so for that presentation, that was amazing. That message was amazing.
Yeah, I think I was just going to say the planning is key. Planning the pregnancy, planning postpartum, as you said, is key. So the earlier you start thinking about it, the earlier you can start talking to people and gathering the information with which you can make informed decisions. And then you know how to balance the risk and benefit.
Perfect. Can there be a malformation in the child if the male is on medication, on epilepsy AEDs, but the female does not have epilepsy?
Truthfully speaking, I have not looked at that. So I'm concerned that my answer would be inaccurate. I'm not going to answer that. I know mostly what happens with exposure to anti-epileptics of the fetus in a pregnant woman. I'm not sure, and I don't know enough about whether there's exposure through sperm. So I won't be able to answer that.
Well, that was amazing presentation, Tejal. I just wanted to let you know the video didn't play, so we will put it up afterwards so people can watch it, and that because it is a very, very informative. It played, so that's okay. If you would just stay with me, stay with us. I'm just letting people know that we have some other webinars coming up, and we have our virtual cocktail party for our culinary showdown. So if you would like to be involved with that, it's a webinar on Thursday at 6 o'clock. So you can just email us and ask for Trevor, or you can look it up on our social media. Our next webinar is on July 20th, and it's about human rights in epilepsy with two lawyers, and it will be very informative for some of you that have had some employment concerns and any legalities regarding your epilepsy. That will be a very informative session for you. Information or
I'm sorry, you broke up a little bit, so I didn't catch the end bit. I don't know if you're asking me a question or not.
I'm so sorry. I think Zoom is just so overwhelmed today. I would just like to thank you so much for your information and your presentation and providing, your wealth of knowledge to all of us in this format.
Thank you for inviting me. I was delighted to chat about this. So thank you for the opportunity.